Hey everyone, welcome back to my podcast Suchitra's Life with me Suchitra. And in today's episode, I managed to talk to Mr. Abbirooban, who is a certified clinical psychologist and also a full-time lecturer. So let's dive into the conversation wherein I'll be asking him lots and lots of questions, and he has been quite kind enough to answer all of my questions that my mind could make up. So, here's the conversation for you all. Hi, Abbirooban. Welcome to my podcast. How are you doing today?
Hi, sister. It's going good today. I'm really excited to what we're going to discuss today as well. Yes.
Great, great. So, before we begin, Abbirooban, I'd like to know a bit about your background. Like, where are you from? What's your work experience? And, slowly we can go ahead.
Sure. So basically, I'm from psychology background, and I did my UG, that's BSc in psychology, and as well as PG, that is MSc in applied psychology from the same college, BSc College of Arts and Science. And later on, I went at MIPMAD, which is in Chennai, to pursue my MPhil in clinical psychology. So I'm actually an RCI registered clinical psychologist. So that's the professional background, like educational background of mine. And apart from that, I'm currently working as an assistant professor in PhD College of Arts and Science again, Coimbatore. It's in the same college, but a different department. Like I studied in aided versus now in the SL financing department. And although I like teaching very much, so I took the full-time job with the assistant professor. I still have like my passion towards working with the mental health populations and those issues. So I do take in like consult clients and visit people with mental issues as well. That's been my part-time work aspect as well.
Great.
Yes, I do freelance on that side, and most of them would be like online sessions. And sometimes I do provide like home visits in case of, especially with the elderly population, with them. And yes, and sometimes I do consult or visit some clinics in nearby localities as well.
That's absolutely great. And what exactly inspired you to become a clinical psychologist?
Okay, to be honest, like the passion towards psychology all started from my childhood, wherein I watched this Tamil movie of Chandramukhi, which in like was in other languages as well, like Manchitrattalu in Malayalam and Nagavali in Telugu. So the main hero character was the inspiration for me back then. But once I was about to finish my higher secondary school, the 11th, 12th, I just understood psychology very different from that, and that psychiatry was different from psychology. And me personally, someone who is not very much into medications back then, prefer like spending more time the talk therapy kind of thing, wherein people get to open up their mind and share their emotions, all those parts. So we wanted to get into psychology. So once I got into psychology, then I realized that psychology is a huge area with its own like lot of subfields within it, and eventually found that clinical psychology is a very specific area wherein the professionals deal with mental health directly, mental issues directly, especially like people who are diagnosable, who are having diagnosable conditions. And one important aspect that I found in India is that a proper recognition would be given, especially to someone from the clinical psychology background, because we do have mental health acts which specify clinical psychology to be a specific discipline, whereas like we don't have other disciplines having such clear-cut boundaries and description about what their qualification should be. So I thought like, okay, fine, I'm already interested in this particular field, so let me go ahead with this. So this is how it started again over there.
Great, great. And earlier in the conversation, you said, psychiatry is different from clinical psychology. So for our listeners, would you mind telling what exactly.
Definitely, definitely. That's a very important aspect to be understood. On the outline, psychiatrists or people from medical background, like say for example, someone would have definitely have completed their MBBS and then they might have did their psychiatry like MD or DNB, something along those lines. So basically, they are from the medical background who are licensed to provide medications, obviously. Whereas psychologists and clinical psychologists are not from a non-medical background, so they are not at all eligible to prescribe medications. And obviously, psychologists or clinical psychologists usually rely more on the talk therapy or the interaction phase wherein you discuss things emotionally, and we use our own techniques of talking. People, when it comes to like talk therapy or counseling, people think that it's just like talking to any other friends and family or something like that. But counseling and therapy, the talk therapy is completely different from how you talk to your friends. We do have our own set of rules and how our own ways to deal with the emotional distress someone might be going around. So this is how it's like different. And clinical psychology in very specific is different from other branches of psychology in the way that it's focused more on someone with a diagnosis of the condition. To put it very simple, someone with a heart attack will not just go consult a general physician, right? So they have to go to a specialist who is trained in dealing with that diagnosis of the condition. So they would rather go to a cardiologist, and only a cardiologist can deal with the heart attack. Not a general physician cannot deal with. Yes, of course he can provide first aid, but he cannot directly treat someone with a heart attack. So similarly, if someone has got a psychological disorder, a diagnosis of the condition, let's say depression, they can only be treated by someone from clinical psychology or something along those background, unless there's like they can provide support to someone with a diagnosis of condition. But clinical psychologists are the ones who directly are trained in working with diagnosable conditions.
Mm-hmm. Okay. All right. So thank you for, giving that clarification. So, Abbirooban, just wanted to know, like, what are the challenges that you face as a clinical psychologist, be it in terms of getting your RCI
Hmm.
certification or, the license, or dealing with the people who are seeking your help. So, what are the challenges in your specific field?
Okay, to start with a lighter note, one major challenge we have here is that we have to study a lot actually. Like in terms of years, it takes at least of 7 years. So 3 years of UG, 2 years of PG, and another 2 years in MPhil. It just literally takes 7 years at least on the study plot. And to be very frank about this, very little amount of males are here in this particular field who go on to continue in the psychology field as well. To share about my personal experience, in my UG batch, there are only like less than a single digit boys were there, like only 8 boys were there, whereas we had like at least 50 girls in our classroom. So that was one major challenge that we all male students actually had to deal with, because you have a very little amount of people from the same gender and you feel that you miss out on something in college. So this has been a very trivial challenge obviously, but to get that RCI aspect involved, it takes a lot of years for us to prepare, because only if you finish the MPhil in specific specialization of clinical psychology, we would be provided with the RCI license, or rather that RCI registration. So that's again like enormous amount of years of studies and academic works to be done. And even within the course, it's very limited. Again, you don't find many colleges offering that. Especially only the metro cities mostly have these courses available. So again, that's a big challenge that we have to like get us prepared to move to the metro cities, especially from people like me who are from non-metro cities. And sometimes we might have to cross borders to different states, adapt to that culture and language, because as I told you, psychology is more about talking. you need to learn or master the local language as well. So in such cases, if you don't know about like other languages, if you're not familiar with other state languages, then it's very difficult for us to cross borders. So some of my friends have had these difficulties crossing borders and trying to learn the native language. It's a challenge that comes with the infil aspect as well.
True.
And apart from that, when it comes to practice during our MPhil days and as well as that, the main challenge we are focused is the mental stigma and taboo that we have. Right, so some people very hectic towards, like very hesitant towards, rather, to be honest, like very hesitant towards seeking help or professional assistance in terms of their mental health issues. So that's one major challenge that we have as part of this. And even once they come in and after seeing what happens in the process, they feel like, okay, this is only just mere talking that's going to take place. This person is not going to give me any medications or any random blood test or something like that. Okay, this I can get it done for my friends, so why should I pay for this person? And sometimes the charges seem pretty hectic, heavy because we charge for an hour of session at least, right? So in that case, they compare it with medical professionals who just spend like 10 to 15 minutes at the stretch. And that comparison obviously is not helping for us because like we do our method of intervention is like 1 hour of talk at least. And that's a challenge that we have as well.
Got it. Got it. And okay, this can be a little silly question that I'm asking. So, like you've said a little while ago that men don't seem to pursue psychology lot. So why is that? Like, I mean, we see male doctors, they are there. Why not male psychologists? Why? I mean, like in your classroom, there was a single digit.
Yes.
And they don't.
So my understanding is that you've got to like study for a longer number of years. Yes, that's going to be hectic. And one more thing is that, especially with the field, is that the pay when you choose any field of study or any field of work, anyone would obviously look for or inquire about the pay that you can get after getting to the field. So that's a pretty big challenge that we have in this field. Again, psychology, the awareness and the growth of the field has been only of late. To be honest, it was a very underestimated course until before COVID came in. Only after COVID, we could see people going through a lot of mental distress, and then they started seeking professionals, and then people started getting more awareness about these fields and the importance of mental health issues. All these came into limelight around this COVID and lockdown phase. And until before that, the salary and average salary would obviously be very lesser than what an individual would be aspiring for. At least like if you compare with someone who is working in an MNC or an IT field, this is like doesn't even pay at least like 40% of it. Even 40% is too high before COVID. But maybe that's one factor because in our society, another stigma we have is that males are expected to earn more and have a sustainable family. And even like searching for a life partner, people expect the males to earn more, and people do calculate all these input-output ratios, like how much am I spending, how many years are I putting into it, how much am I getting back for that. So that's one major factor. Yes, obviously the amount of salary or remuneration that is being paid is definitely a very major factor in this. And one more aspect, another superstition or any stigma might be is that psychology is more about the emotions, the exchange of emotions and processing all these things. And the taboo or the superstition is that males are not really good in emotional part. And they are not very good of listeners, especially when you want someone to have conversation for going for at least 1 hour. They believe that men are not made up for this. They might get tired easily, or they might be so good in processing emotions. But females might be able to process that better. So that again might be a factor, especially when parents negotiating with their children about pursuing a field in psychology.
Mm.
That might be playing a major factor as well, because I've come here about like a couple of my male friends who are my schoolmates saying this as a reason to not join into psychology as well. So these are the two major factors I've seen myself and I've experienced, and I believe these are the two major factors which might be the reason behind males not pursuing much into psychology here.
Got it. Got it. Thank you for putting those things in the front. And so during you freelance as a therapist, right?
Mm-hmm.
What are some of the most common mental health issues that you have encountered in your practice so far, like across the ages, and
Mm-hmm.
when you categorize age-wise, or
Yes, sure, right, I get it.
general age-wise, gender-wise, any which way.
Sure. So basically, like my MPhil days were at an institute like NIPMED, which is actually a central government institute for persons with multiple disabilities. So that center was very much focused on catering to the needs of people with disabilities. And we do have certain mental health issues that is considered as a disability as per the one particular act which we called as the RPWD Act of Indian government. So in that we had like major disorders of like developmental disabilities, which includes disorders like autism, IDD, intellectual disability, formerly known as MR, or mental retardation, and learning disabilities. These are the primary uh, disorders that people would come up to us with. And so my major exposure was along those areas, especially children population, and sometimes people who require disability certification or recommendations for strike during their exams would be referred to our institute from the state resources. So just before the 10th, 11th, 12th exams, all those students will be referred to us by various schools as well. So majorly my training phase focused more on working along with children. So among those children, I was very clearly able to see the ADHD, LD, autism, and the IDD or the former MR to be very common disorders among those populations. And when it comes to like the adult population, it was more about like schizophrenia, depression, and some anxiety disorders were very common back then. And after my training phase, when it came to my private practice as well, most of the clients of mine were also like mostly from the children population. Again, the very common notion or common understanding that I have about this is that parents are always ready to go take in more efforts or go that extra mile so that they can help their children in better ways. So if they see a child with some difficulties, they would like to like go to that extra mile and break all the taboos and consult a psychiatrist or a psychologist for that issue. And among children, again, most common or very distinguishing features would be presented among children with the disorders like autism, ADHD, which is like very significant feature that distinguishes them from any normal child, any healthy child to be with, rather. And apart from that, some people might bring in children with any behavioral issues. Say, for example, a child might be with a lot of temper tantrums, frequent temper tantrums, wherein the child is very adamant in behavior, all those things.
Oh, okay, great. That dealing with children was during your training phase.
Yes.
As a freelancer, what are the type of people you deal with? Like, is it children or adults?
Okay, on that part, like, I believe that being a fresher into the field, I should be exploring around so that I shall like understand from my experience, okay, which is working and which is not working, And personally, I don't feel like restricting ourselves to one particular population will be very helpful for our career or any aspect for that matter. So I was really very open to working with different populations, and I have like worked with adults and the elderly population as well. And to throw some extra light on what kind of disorders that I was working with in case of adults and the elderly population is that most of the cases the dementia was very common in the elderly population. And apart from that, the like post-retirement crisis, say for example, they would have led a very busy life during their working phase, and out of nowhere the retirement comes in, and they struggle a lot to understand what is happening around, what to do, and all these factors lead to that what we call as a depression as well in the elderly age. And that's very common. Dementia and depression are the very common disorders that I have been dealing with in case of the elderly population. When it comes to the late adolescence or the adulthood phase, again, it varies, of course, like anxiety disorders or depression. These are the very common aspects that I've been dealing with as well. And of late, I've been seeing a few female clients coming up with anxiety and depression, wherein like they were actually supposed to be like secondary disorders. And usually, as part of the treatment phase, we do start with case history, like wherein we collect details of right from their childhood to their adulthood. Therein, I found a few clients with history of some traumatic experience like sexual abuse, especially. So all those aspects have been like very common among females as well. That's a very important aspect that I've been handling as well.
Okay. So, so when a female patient walks in, I'm just asking because I'm a little curious because women prefer a women, psychologist.
Yes.
So do they hesitate before opening up to you, or how do you make them feel like safe, comfortable, and I think
Yes, that's really there. The gender aspect of talking to a male therapist or any male medical professional regarding something as very sensitive as something like a traumatic experience of sexual abuse. Yes, that has happened. But as I told you, they start off with something that is way different or way distant from the sexual abuse cases. So they just come to me or reach out to me on the fact that they are suffering from some sort of anxiety issues or some depressive features. And once we get along, like in technical terms, we call it as a rapport establishment, wherein we build that comfort with the client and build the trust among them. Once that sets in and once they feel that we are able to provide that non-judgmental space, okay, this therapist is not going to judge me for anything, he's not going to blame me for anything, no victim blaming is going to happen to me. Once this has been established, that's when they start opening what could be the issue. Yes, as a psychologist, as a therapist, I can sense some issue that, okay, this person's features seem like they have had an adverse childhood experience, like something negative must have happened in their childhood. But still, we cannot predict accurately that, okay, this person has definitely been abused. We cannot say that, obviously. So when we sense that, we tend to just try to encourage them to or provide them that comfort space so that they can open up. That's when they open up gradually that, okay, yes, there was a negative experience during my childhood and I'm very hesitant about it. That's how they start. And since we have already established that confidence and safety to them, kind of feel to them, they start opening about their sexual abuse that has happened to them. And then as a therapist, I start explaining how that could have impacted their mental health and how could that disturb their regular functioning as well. This is how things happen. So that's when they feel comfortable. Yes, someone starting off to seek therapy for their sexual abuse or something like that, yes, they might not be preferring a male therapist. That's a very important thing to be considered. But most of the times, people don't reach out to professionals for uh, dealing with their sexual abuse or the negative impact of their sexual abuse. It starts from somewhere and it goes back to that history of sexual abuse or something like that. And so in that way, if we see, yes, there is already confidence being built between built upon the therapist being able to help the client, and there is trust being developed, and a non-judgmental space being built over for that client. So now they feel, okay, I can trust this therapist with my sensitive issues.
Okay. So I have one doubt you can have. So, do you like at any point of time during your session, do you take this call that okay, maybe talk therapy is not something that is going to suit this person? I should recommend them a psychiatrist. So who exactly takes this call of approaching a psychiatrist? Like, how does a patient who wants help, how do they even make the choice of opting for a psychiatrist or a psychologist? How can they even know that
Okay,
to whom they can?
fine. Okay, I do get it. So in this case, in our field, we have this particular aspect that guides us. Okay, so we cannot take decisions for the client unless they have something that impairs their decision making fully, like especially their intelligence or in general, their intellectual capacity, to be honest. Unless it is impaired, we don't take decisions for them. That's what the basics of our profession is all about. It's one of our professional ethics. So in case we suspect that this person might need a psychiatrist, is that we tend to provide the facts, or we tend to present the facts to the client and their caregivers. Okay, so this seems a bit of a like kind of a disorder. It's not like something that we can just talk it out. And obviously, in most of the cases, we do refer the clients to a psychiatrist as well. Because, to put it very simple, so that everyone can understand, I just draw an example or parallel from physiological disorder, which is like diabetes or the sugar that we commonly call, right? So in case of diabetes, the treatment will start with consulting a diabetologist or a doctor who provides medications. Yes. But the treatment regimen is not going to restrict itself to just medication. Yes, the diabetic patient will be consuming medications, and they will be having a dietary plan, and they will be having a plan for them to keep them physically active, such as like exercise or walking, something like that. And they have to focus on their food intake and timing, especially the schedule and sleep schedule. So it's not one particular entity or one particular person or one particular approach that is going to help them deal with that particular disorder. Okay, I'm on medication, so let me have the sweet and let me have sugar, consume sugar as much as possible. No, it's not going to happen like that. They have to balance all these things together so that they can achieve their goal of dealing with the diabetes in a successful way. So similarly, even in case of mental health issues, we are going to definitely refer the client to a psychiatrist or neurologist based on their condition. For example, in case of dementia, a neurologist will be more apt to work with the client rather than a psychiatrist. So definitely we are going to refer them to the medical professionals, and sometimes in some cases we might require the help of other paramedical professionals like speech therapists or an occupational therapist or a physiotherapist, some people like that. So we explain the client what is required and why is it required to go consult that other specialist as well, and why is it important to work with all the professionals together, because treatment is not going to be a one therapist and one client aspect. It's obviously going to be a team of people working together to achieve that better health aspect as well.
Got it.
So we just provide the information that is required.
Mm-hmm.
And in very serious cases, say for example, there are a few disorders, example like schizophrenia or a chronic depression, would definitely require a psychiatrist working. So in that case, we 100% recommend them to a psychiatrist. We make sure that they go consult a psychiatrist. Unless it is this severe, we don't press that consultation to them or recommendation to them. But still, we explain them the pros and cons of consulting other professionals as well. So we leave the decision for the client to take, but still we strongly recommend them to be consulting with other professionals as well.
Got it. Got it. And what are the most important skills that a clinical psychologist should possess? Like from your own experience, what do you think are the necessary skills that one should have
Okay.
to become
Yes.
clinical?
So apart from the technical skills, like say for example, understanding the background of the client or like aligning their history with the theories that we have studied as part of the courses.
Mm-hmm.
One major non-technical skill that we would have to like master is how you interact with the client, what we call as rapport building, all those elements. Because it's going to be a session of talking between the therapist and the client. Yes, it's going to seem like talking, but it's not an ordinary talk that you're going to have. As I told you, it's not like you're going to go talk to your friend or family member. So that difference should be seen, and it is marked by building a good rapport wherein like they feel comfort with you. See, you're not going to open to your friend about your financial issues or any mental health issues or any issues directly to your new friend that you have got from your new job or a new college. You're not going to do that. You're going to build a friendship over the months or at least a few days so that you can share things with them. And the client is someone who's going to come straight away and going to share their issues with you. So it's very important that you build that rapport as soon as possible and in a very strong manner as possible. Only then they'll be able to like open up all their significant issues as well. If unless the client is going to open up about their issues, we as professionals cannot assess them in the proper way. Also, people do believe that psychologists can read their minds or predict things. That's again actually a myth, to be honest, because we cannot like read minds as in like the movies have shown.
Yeah.
So in that case, rapport establishment or rapport building is a very important skill, and there are other factors like say for example, developing the empathy towards the client is very important. Yes, obviously sometimes when few clients share their experiences, they seem very horrible. We do feel that it shouldn't have happened. Sorry. So they shouldn't have happened to any individuals across. Yes, those kind of horrible things might be presented as well. But even in that case, to hold your emotions, to manage your emotions, and not cross the boundary of empathy into sympathy is something that is very important as well. So these are the two major skills that is very important apart from n number of skills or technical skills that is required to be a successful psychologist as well.
Got it. And Abbirooban, how do you approach treating patients with different cultural backgrounds? Like some people from a cultural background may or may not be open to certain treatment or techniques that you're trying to bring in. So how do you deal with such instances, or did they ever happen?
Okay, so to start with, like for a fresher who is not really worked with different cultures or people from different cultures, it would be very plain and simple. You try to just understand the emotions that they are going through and their belief system. Say, for example, someone might be an atheist or someone might be a theist, someone might be from a patriarchal background, someone might be from a feminist background. So regardless of the background that they are coming from, you just have to try to understand their point of view. That's very basic to the sessions, to be honest. Yes, some things might not work. Say, for example, again, the patriarchy, when we are speaking about it, yes, it's not something that should be encouraged, especially from our professional point of view. Yes, that is there. But you cannot carry your own aspects or point of views into the sessions. So as long as that is kept away, our point of view, our understanding, our perspectives, our values are kept away, and one can manage those aspects and give more importance to the client's perspectives and their values. This cultural background will not seem really a big factor, to be honest. And yes, still there will be a lot of challenges, and that's why a counseling session or a therapy session isn't going to be a one-day affair. It's obviously definitely going to take at least like 10 to 15 sessions, like 2 to 3 months for us to like completely work with the client and help, like assist them in seeing that vast changes that they would have decided for. And over a period of time, we would definitely recommend the professionals or the therapists to get themselves familiar with various cultures. And even at the first place, if we are not really familiar with that particular culture, if we are not really being comfortable with that culture, it is always necessary to refer them to some other therapist or counselor who is really good at dealing with people from that particular cultural background. That's very important, because if you don't think you can build a good relationship with the client, the professional relationship with the client, and you are not able to understand the cultural background and nuances of that client, you cannot definitely work well with the client as well. So recommendation would be to refer them to someone else who could be doing that. Yes, there are some cases wherein you will not get referrals to be made. It might be an emergency. Yes, in that case, yes, of course, regardless of the cultural understanding, we can take in that client and handle the sessions for them. But still, be open-minded as much as possible. Just be open to their experiences. Keep away our own beliefs and values, and rather be accepting their cultural background and their value system.
Got it. Thank you for clarifying that. And I'll be asking very simple questions, because this is what I kind of get in my head right now. So, for example, let's say I'm just having a bad day, but I go to the internet and I search like, why am I feeling, what am I feeling, and then I'm like self-diagnosing myself like, oh my god, I'm depressed. So, most of the people out there tend to do this to justify what they're feeling.
Yes.
So, as a therapist and a mental health practitioner, how do you differentiate that a person who's reached out, is he actually having an issue, or he's just feeling a temporary emotion of sadness or anger or whatever? How does that differentiation happen? Like from a layman's perspective, how does that happen?
Yes. Okay. So, when it comes to diagnosing someone, when it comes to like understanding whether someone has really got a very severe issue, or is it like one bad day and after that they are Googled and that's the impact that has brought them here, we tend to follow strictly about something which we have it as the diagnostic guidelines. Like, say for example, a doctor could say you have like malaria, you have dengue, or you have COVID, based on the symptoms as well as the blood test results, or any test results that they get from lab as well. So similar to that, we do have our own like set of assessments that we do make rather than tests, and we do have certain criteria. Say for example, we do have experience. We all must have experienced sadness for an entire day, maybe like lost sleep over a couple of days, and not being able to have food in a proper way. Yes, this is very similar to the depressive features we have as part of the clinical aspect. But one major feature that we would look for here for is the duration for which these disturbances are persistent in the client. That's a very crux that we'll be looking for about. Say, for example, someone who can be diagnosed with depression should have all these disturbances and many more other disturbances as well for a quite a period of time, like say, let's say just at least 2 weeks on a continuous shot as well. So similarly, we have like certain criteria for various disorders, and that's how we diagnose it. And sometimes we do have certain complicated circumstances wherein it will very closely resemble the diagnostic guidelines. But in fact, it might not be an actual disorder, but it could be a just a deviation in the normal functioning of that individual, like they getting deviate or some intermittent challenges that they are facing in their life. In such cases, again, we do rely upon our own clinical training based on our observations of other persons with disorders, and we do talk on comparisons over there as well. But mostly, we do rely on our guidelines that have been established. WHO has published a book for this, wherein we refer all the diagnostic guidelines that is being given over there. And it's not like we blindly follow the book. Yes, if someone is going to blindly follow the book, then everyone can get their hands on their book and try to see, okay, this symptom is present, this disturbance is not present. Yes, they can do that. But the understanding and the training that we get over the period of time helps us actually differentiate whether it's a one-day affair or it's an actually a serious condition that has got over there.
Well, that is part one of my conversation with Mr. Abbirooban. Stay tuned for the part two that will be released at the end of this week.